Hi, I'm Dr. Ashley DeLeon. I'm a board-certified general and trauma surgeon and fellowship-trained transgender surgeon practicing at the Crane Center for Transgender Surgery. We are a group of several surgeons who, we have multiple locations in the U.S., who provide surgical options from head to toe for trans men, trans women, and non-binary gender fluid individuals. Our collective backgrounds encompass plastic surgery, urology, reconstructive urology, general and colorectal surgery, craniofacial surgery, microsurgery, and gynecology. And we've all quit our day jobs, so to speak, and dedicated our careers to the trans community. We perform gender-affirming surgeries for patients that come to us from all over the world and are proud to say we provide both comprehensive and compassionate transgender surgical care. So today we're going to be discussing how we approach the insurance companies to get your medically necessary procedures covered, and specifically we're going to be discussing this in regards to vaginoplasty revisions. So we've come a long way since Dr. Crane started this practice back in 2012, when only about 10 to 15% of our patients were covered by their insurance. And so the majority of our patients were having to bear the financial burden of their procedure completely alone. So Dr. Crane not only pioneered and perfected a lot of the operations that we do today, but he was also one of the first transgender surgeons to say, hey, we'll work with any insurance company. And so since that time, through a lot of hard work on our part and yours, battling trans exclusion policies, which are now considered illegal, fortunately, and persuading politicians to do the right thing for the trans community, we are really proud to say that 85 to 90% of our cases are now all insurance-based. That's incredible considering where we came from and where we started. So what I want to share with you today is kind of what goes on behind the scenes with the insurance companies and our practice during the authorization process. So this involves personally advocating for you, with our ultimate goal being that the insurance company will approve your entire procedure. So at the Crane Center for Transgender Surgery, we have an entire team of experts in billing and insurance that we employ specifically to help us get your medically necessary procedures approved. So how it works, this team initially is going to submit a list of codes called CPT codes to the insurance company for approval that encompass the various procedures we plan on doing while we're performing your surgery in the operating room. So once the insurance then receives our codes, so they can then do one of three things. They can approve all of them, and then great, we're done. They can approve none of them, and they can approve only part of the codes that we submit. So should any of the codes get denied for your surgery, then the next step is to submit an appeal on your behalf. So part of this process often involves what's called a peer-to-peer review or peer-to-peer call between your gender affirmation surgeon, such as myself, and then another physician who is actually employed by the insurance company. So the insurance company's physician is often a primary care physician of some sort and may not understand all the different nuances of surgery, especially gender affirming surgeries, but they do have a good baseline, they're knowledgeable, in other words, about medicine in general, so we can have an educated discussion. So then it is on our job as your surgeon to have this discussion with them in order to help them understand why your procedure is medically necessary and thus why your procedure should be covered. So specifically today, with vaginoplasty revisions, we sometimes, get denials from the insurance companies, despite the fact that they covered the initial operation or the initial vaginoplasty. So let's look first, okay, because if they deny revisions, even though they covered the vaginoplasty, now let's look at some background information, because the main denial that I get with vaginoplasty revisions is that they say it's cosmetic, okay? So let's look at some background information and talk about cosmetic versus reconstructive procedures. So a cosmetic procedure is when we are taking something that is considered normal and we are enhancing it surgically. So the example I always use, because it's the same procedure just for different reasons, is breast implantation. So for me, for example, as a cis female, if I wanted breast implants placed, That would be in order to make my breasts larger or to enhance them or to augment them. And so in that case, placing breast implants is considered a cosmetic procedure. It's enhancing something that's already considered normal. So for a reconstructive procedure, if you take something that's considered abnormal, then and you change it or reconstruct it to something that is considered normal, then that is the definition of a reconstructive operation. So, for example, if you take a cis female who perhaps has breast cancer and has had mastectomies to have their breasts removed in order to treat the cancer, if we're putting breast implants in these patients, it's considered reconstructive, which makes sense because we're taking something abnormal, which is a cis female that has no breasts, and we are reconstructing that then to make it normal. They're going to have a breast and nipples to appear normal, and that's why this then is deemed a reconstructive procedure, not cosmetic. So keeping all that in mind, when I'm doing a peer-to-peer review with the insurance company's physician to appeal a denial for various vaginoplasty revisions, I utilize this information then to kind of build a compelling argument and hopefully overturn their denial. And so using this example of implants and breast reconstruction for cancer patients, it's a good example to help them kind of understand the differences and similarities, since insurance companies always cover breast reconstruction since there was huge lobbying and advocating in the 1980s for this. They now cover all of that, as they should, but we want them to understand why it shouldn't be looked at any differently with vaginoplasty revisions in trans women. And so then it allows us to kind of discuss the differences between cosmetic and reconstructive procedures. So vaginoplasty revisions can vary greatly, as I'm sure you can imagine. I like to break them up really into 3 categories. So I have revisions of the urethra, revisions of the vaginal canal, and revisions of the vulva. So for both urethral revisions and vaginal canal revisions, we often don't have as much trouble or as many issues getting those covered, considering these structures, the urethra and the canal, affect function. So, for example, for urethral revisions, the abnormality is often causing unhygienic urination. Let's say the urethra wasn't shortened enough, and so when you sit down to sit and urinate, the urine is propelled forward and out of the toilet. That's unhygienic urination. That's a medical diagnosis that the insurance company recognizes as medical necessity and thus often covers the procedure. It's a similar story for vaginal canal revisions. So if you have, for example, a ring scar contracture, a tight area in your canal that you can't push past. Maybe you have vaginal prolapse where the graft or something falls out of the canal, or complete vaginal stenosis, which is when your entire vaginal canal scars and closes down to where you cannot utilize your canal anymore, okay? Then for all these things, you're not able to really fully utilize the canal for proper dilations, for penetrative intercourse, or for anything similar to that, which can cause the patient distress, anxiety, and it can also worsen dysphoria. So again, in these circumstances, it obviously affects the patient's functional purpose of her vaginal canal. And so it's an easier argument should we run into any pushback from the insurance companies in order to get those types of revisions covered, okay? So those are the first 2 categories. The third category I mentioned is what we're gonna spend most of our time discussing, which is vulvar revisions, okay? So revisions of the vulva, or the external female genitalia, okay? In this area, this is the more common area that we get denials. So during vulvar revisions, we may be revising the clitoris, the clitoral prepuce, which is the clitoral hood, labia majora, or possibly the labia minora, okay? And the goals of these revisions are not for function necessarily, but more so that the patient can have a vulva that's normal, quote unquote, in appearance to and similar to a cis female's vulva, so that it looks natural, okay? So let's look first at revisions of the clitoris and the clitoral the clitoral hood. Or actually, let's look at revisions of the clitoris and revisions of the labia majora. Let's do that first. So if you take these two examples of revising the vulva, when we revise the clitoris, oftentimes the most common revision that we have requested is to make the clitoris smaller. So we often make the clitoris larger initially during the operation. And it's purposeful because this structure, after we've reconstructed everything during the healing process, will often atrophy, which means get smaller. So we want you to have good sensation. So we create a larger clitoris, and we're anticipating over time that this is going to atrophy or get smaller as things are healing, and then end up kind of the perfect size and look natural. Occasionally, that doesn't happen, and patients have a more prominent, large, visible clitoris. In this case, the argument, again, is a little bit easier with the insurance companies to get it covered, because even though this has to do with the external genitalia, like what people are seeing with your vulva, even that being said, it can create a functional problem. If you have an enlarged or an oversized, clitoris, sometimes that can be very hypersensitive. It may rub against your clothing when you're dressed and cause discomfort or hypersensitivity. And so if this is the revision that you're requesting through your insurance company to have coverage during your vaginoplasty revisions, that's typically the argument for that specific thing that I give in order to help that physician understand the medical necessity of decreasing and reducing the size of the clitoris to a more natural or normal size of a cis female's clitoris. Because again, that can also affect function. Okay, so now the other vulvar revision that I mentioned, the labia majora. So sometimes the labia majora, perhaps they're too big. Maybe they just healed, they didn't atrophy or efface, which again means kind of flatten, as swelling went down, and so you have very prominent labia majora. Maybe they have a big scar on them with train tracking that you don't like, or maybe they kind of stick up or have dog ears at the top that you want revised. So anytime we're doing work with the labia majora, which are the outer and larger labia, when we're doing that, this can also actually affect function. So this can cause something called dyspareunia. Dyspareunia is a fancy doctor word, which basically means that you have painful penetrative intercourse. So if you're inserting your dilator, or if you're having penetrative intercourse, or anything of that nature where you're inserting something into the vaginal canal, it can cause some discomfort. And so in that case, if it's primarily revisions to fix the labia majora, then I often utilize that functionality as an example for the insurance company physician, for them to understand that this does have a functional implication to the patient, and that's why it's a medically necessary procedure that should be covered, so that we're able to revise those, and then we can go in and do scar revisions and fix the dog ears and make them a little bit more symmetric and less prominent, in order to kind of help and fix with that medical diagnosis of dyspareunia. Okay, so that's half of the vulvar revisions that we see most commonly. The other two that I mentioned previously get a little bit more difficult to have a discussion with the insurance company about, as far as the medical necessity. They deem they're cosmetic, and those two that I mentioned previously are going to be your labia minora and your clitoral prepuce, which is your hood. Okay. So these don't necessarily serve a functional purpose. However, the two common things we see for both the clitoral hood or prepuce, and also the labia minora, is that the labia minora, which are normally very thin mucosal structures for cis women, we have to create them from regular skin, not mucosa, and we do this by bunching up that skin or that tissue to create a roll or a line that gives you that definition of labia minora located more centrally. Okay, as things heal, over time, then what can happen as your body heals is your body can flatten them. It's a process called effacement. And as your body heals, if it happens to flatten one or maybe both of your labia minora, either maybe the same or to varying degrees, then that is a revision that we commonly see requested to revise the labia minora. Okay, and then the clitoral hood or the clitoral prepuce is a similar situation. Cis females have a clitoral hood. It's analogous to the foreskin in a male that covers and overlies the penis. These are analogous embryologic structures. So all cis females have a clitoral hood. So sometimes during the initial operation, during vaginoplasty, it can be difficult to create a clitoral hood that's prominent enough to be visible for trans females. We've done a lot of different techniques to perfect that over the years and are a lot more successful with having you heal with a clitoral hood or prepuce after the initial operation. However, sometimes you still just don't have a prominent clitoral hood once it's all said and done. If that's the case, that's a structure that's normally present in a cis female's vulva, similar to labia minora. Labia minora are a structure that's present in a cis female's vulva. So if we're doing revisions of that nature, the insurance companies always say that that's cosmetic and it's not reconstructive. So if that's the case, and if it's one of these things that they're denying, maybe they've approved a bunch of other codes for small other, revisions that they say, okay, that's functional, we'll cover it. But maybe these, they don't, right? So if that's the case, then what I typically will say to the insurance company's physician when we're doing our peer-to-peer call, trying to get your medically necessary, procedures approved in full, then, we kind of have that discussion of, I ask them, do you think it's normal, for a female to have a clitoral hood or a prepuce? Or do you feel it's normal for a female to have labia minora? And they can't deny that the answer is yes. So then I say, okay, well, if the converse is, if you agree to that, if you agree that it's normal for a female to have a clitoral hood or labia minora as part of their external genitalia, then you have to agree the converse is true, right? That it would be considered abnormal if a patient didn't have any labia minora, or maybe didn't have one labia minora, or maybe they didn't have a clitoral hood or clitoral prepuce, and so they had a very prominent clitoris because it wasn't covered properly. For those kind of things, they have to agree that yes, if that's the case, then that's considered abnormal. So when we're doing those particular revisions, what we're doing is we're taking a structure in a trans woman that is abnormal because they have healed without a prominent, clitoral hood or prepuce, or they've healed with asymmetric labia minora, or, one's flattened or maybe both have flattened and they're just not visible anymore. So if that's the case, that's then considered abnormal because a female should have a hood and labia minora, right? So if that's the case, then I say, well, if you agree that that's abnormal, then can you not see what we're doing here with these revisions is we are taking an abnormal process, an abnormal structure, which is the absence of labia minora or a clitoral prepuce or hood, and we are reconstructing it then to make it normal, quote unquote, so that they can have labia minora or a clitoral hood or clitoral prepuce, right? And so then, once they've acknowledged, yeah, that's abnormal for them not to have it. Well, then does that sound familiar, that argument that, you can have an abnormal structure and we're going to reconstruct it to make it normal? It should. It's the exact definition of what classifies a reconstructive procedure. So that is, kind of our argument with the insurance company's physicians. I say, well, if you can cover a breast cancer patient, for example, that's having, their breasts reconstructed because it's abnormal for a female not to have breasts. And we're going to reconstruct that. Even though they're not functional, we're reconstructing those and y'all are covering that as they should, to make that female normal again because it's abnormal not to have breasts. It's the same argument when we're talking about the clitoral hood and the labia minora. It's abnormal for a woman or a female not to have those structures. And so by doing these specific vaginoplasty revisions, by definition, we are doing a reconstructive procedure, by allowing them to have an abnormal appearing vulva and converting that to a normal appearing vulva that is natural and convincing and appears like a cis female's vulva. So we don't always have success in that regards with those arguments, but we do have some success, and that's how we kind of go to bat for you with the insurance companies. That being said, also keep in mind too, with some of these, procedures and things like that, and vaginoplasty revisions that they deem cosmetic in nature, a lot of times you have to remember, like when you talk about symmetry and different things like that affect the overall outward appearance of a female genitalia or the vulva, when referring to the vagina, it can be, you can have asymmetries and other things that are all considered within normal variant, right? So I spoiler alert, and this is what I say during all my vaginoplasty talks, is that, people always ask, what's the perfect vagina, right? There's no such thing as a perfect vagina. All vaginas are different. There's asymmetries. Nobody's perfectly symmetric. Everybody's is a little bit different. There is no accepted standard for, what a vulva looks like. But that being said, there are specific features of an external vulva that are important to include for a vulva to appear natural in a cis woman or in a trans woman. And so that's how we approach that portion of the revisions with the insurance company to get your procedures covered. Because ultimately what we're asking the insurance company physician to do is to understand that this is a medically necessary reconstructive procedure, and it's to provide mind and body congruence and help alleviate gender dysphoria. So by discussing that also in the context of other procedures that are analogous that they do cover, it's easier for them to see that their policy is inconsistent. And so denying a trans woman vaginoplasty revisions, even if it's for labia minora and clitoral hood or clitoral prepuce, so that they can have a natural appearing vulva, it's discriminatory in nature to deny that for a trans woman. They also do, for the record, cover labiaplasty for cis females who have enlarged labia majora, again, because it causes dyspareunia or painful penetration or painful intercourse. And so for them to deny that for trans women and approve it for a cis women is discriminatory in nature. And that's what we bring to the attention of the insurance company's physician so that they can also help understand that. And so this doesn't guarantee us that the denial is going to be overturned and that we're going to be able to get your procedure approved. However, it provides the insurance company physician with a compelling argument so that he has those tools necessary to go back to his insurance company, because that's his job or her job or whatever. It's the physician's job for that company to serve as a medical liaison between practices or surgeons and physicians with the insurance company, so that he can go back and give them that medically necessary information and help them explain to them why these are deemed reconstructive operations, that they're medically necessary. It's the purpose for alleviating gender dysphoria. And so that gives them more tools to go help affect policy change so that they can ensure that their company is approving these medically necessary procedures for their beneficiaries, but in a non-discriminatory manner. So again, it's not always successful, but we do have a lot of success when we argue it in that fashion and help to get your medically necessary procedures approved. So thank you for listening. I hope this was informative. And if y'all have any questions, you can always email us, or you can also go to our website at www.cranects.com and reach out to our office with any additional questions that you may have. And then also, please keep in mind that the more you are proactive with your insurance company, the better chance we're going to have on the back end of arguing with them and getting your medically necessary procedures approved when we're there fighting for you to get your procedures covered.